achievement of Addiction Medicine Certificate from International Society of Addiction Medicine, Canada, and PCV Awards at TS TSICAN 2021, and first prize for best paper presentation in 9th World Congress of Asian Psychiatry, and his area of interest addiction psychiatry, consultation addiction psychiatry, and specific research or clinical interest in craving and suicide. Other area of interest dual diagnosis, depression, mood disorder, clinical child psychiatry. So, sir, I also eagerly waiting. So, this neuro modulation and neuro intervention, these are the new concept, and we are using technology in real practice. So, everyone very interested to know many things from you, sir. And please start your session, sir.
Thank you, Varshi. Thank you for the sweet words. So, good morning to all. So, today maybe the less number, and let me complete as a informal or formal presentations. Okay. So, regarding the tDCS, so every innovation in the treatment modality, there is a lot much of hope and lot much of rigorous research and the validity about that clinical experiences. So all are the counted to whether it's a withstand in the time evaluation of the psychiatric interventions or not. Yes, in that tDCS is little bit having of some hope on that. So here my intention to presentation is the how we have to translate the research experiences and knowledge into our clinical routine practices. I can label here almost a second pillar of the medical treatment in our psychiatry. So in our routine practices, we all know about that the psychiatric disorders are the brain dysfunctional disorders in terms of the not only neurotransmitters, which are the chemicals which we usually talk about that various psychiatric conditions, even the neurocircuits is a nowadays the concept is the all psychiatric disorders having of the neurocircuitry dysfunctions, various level of the electrical imbalance that happen between the circuits and nodes of the circuits. So these are translated into the behavioral form and the presenting the symptoms in a clusters manner. So this tDCS is now where the stands is a part of the brain stimulation modalities. So among the routine pharmacotherapies and as well as psychological therapies where we have the lot much of years of the decades of the evidence. Now it was the last 2000 onwards, the hundreds and thousands of the papers and RCTs are coming with these brain stimulation modalities. So brain stimulation is nothing but say electrical manipulation of the brain activity, which are the we presume that having of the various from the research and as well as the literature, which are supporting for that electrical activity or level of the hypoactivations or underactivations or hyperactivations. These are the also causing for this abnormalities. So before that, going there, what is this? Mosquito bite. So how much the current it was the transmit when it contact your surface? Is it harm? We all believe that mosquito bats which are there, electrical tool, which we touch our bodies, touch our heads, doesn't happen any abnormal. So same, how much the current will pass? Say 5 milliamperes. Our tDCS we used to give that 2 or less than 2 in general from the literature. In exceptional cases, maybe we go for the 3 also. What is this? Yeah, electric fish. It has the enormous before 2000 BC. We our human innovations having of utilizing this electrical fish, which cover the head of the patient who was having of sufferings for depression, epilepsy disorders, various conditions. So electricity is nothing. We have the long association in modalities of the treatment. Nothing, not a new one. Then coming to the tDCS, it's the low intensity direct current which apply over the scalp and transmit through the electrodes to the brain to modulate the cortex of the brain excitability changes, whether hyper or hypo, based on the anode and cathode related things. The parameters we are using here, the very safer one, and it was tested as a valid and as well as safety for the between less than the 5 milliampere, maybe 2 milliampere either for the various psychiatrical conditions that are safer in terms of literatures. And the session's duration will vary from the 20 minutes to 30 minutes. Even for the single session stroke, FAG conditions, rehabilitation conditions also, we are using for the 15 minutes of session. And where the OCD related, thought related intervention, we have to give the more number of the time duration. So there, according to the clinician requirements of the patient, we have to design these protocols. Coming to the how it works, just a brief about that, deeper neurobiological aspects about that. Yes, it's a applying the direct current doesn't change the action potential. It's a change the resting membrane potential levels, whether it's a hyperexcitability or hypoexcitability changes, whatever. It has the neurotransmitter level of the changes. Once the current was passing through the cortex, the cortex neuronal cells, especially pyramidal neurons, transmit that in that NMDA receptor dependent plasticity changes also. It's need not to only neurotransmitter level, even like a ECT type of the modalities of the neurobiological changes are happening in that plasticity changes like LTP and LTD also, which have the end related the BDNF mediated effects. So there are the vast literature evidence also there. The glutamate related the hyperexcitability going down with the stimulation of this tDCS, and GABA levels, serotonin levels, norepinephrine levels also moderated with these stimulations. So basically, calm modeling related the changes, and as well as CPK related changes, and especially calcium influx, which will be trigger the TRK-B gene pathways also. Eventually, the nucleus started to BDNF proton promoter region activated with the CREB activations. So end proteins are increasing their functional connectivity between the nodes of the neurocircuitries, and as well as this neuronal excitability over a period of time, persistently 20 minutes, 30 minutes of the duration, it evokes the plasticity changes also. So it's nothing but whatever the dendrites which are there over the whether the axon or soma related the thing, the dendrite density increases, and the synapses number also increases, and as well as the bond, the strength of the connectivity also increases. So overall, all these neurobiological changes make them to the valid for the various neuropsychiatrical indications also. And not only that, even the cerebral blood flow, which is the showing the PET scans and functional MRI scans, cerebral blood flow also increases. Various unanswered with the very many medications apart from that opioids, how we have to tackle these endogenous opioid related systems also getting into the activated changes are noted here. So overall, this calcium influx, that just to have told that all these neurobiological changes which was translated into the structural changes in the brain, especially cortex and cortical connectivity through the spine density, spine enlargement, actin cytoskeleton remodeling things. So the metaplasticity changes like a BDNF mediated priming effects, all these are things are activated. In simplistic understanding, can I say it's a if you are the depression, giving a music like a sort of the piano or something, music, the same type of the thoughts are recurring, guilty thoughts. So it's going that once you getting the excitability by this anode excitation of the certain accessible areas of the brain cortex, so it make them to activate it like a rhythms of the music, where the cathode on when you on that, then cathode response will be getting into the activity, hyper excitability cortex areas going to slope down here. So where we have to create the music within the neurons, just what I am saying. If you increase the anode stimulation, the underactivity neurons will be getting to excitability. So how much I can excite? how much the time I can make it to sustain that. So this will lead into the some sort of synaptic plasticity changes also. Like a simply I said, as a band manager, I am there for the various regions, like a, for pain, for depression related, the mood related changes, and sometimes the somatic symptoms also. So where the having of different ways of the abnormalities in that, which area we have to select it as a available literature, available evidence which are accessing us to manipulation of the cortex. We have to select it. So anode nothing but increase the action potential rate chances will be increases, firing threshold also increases, and the responsibility to synaptic input also increases. So cathode is opposite for that. Then coming to the HDTDCS. Here another more modality we see that conventional tDCS to HDTDCS. What is the difference? Yes, tDCS technology going on little bit innovative way. HDTDCS is little bit advancing one also, where we have to precise the location we have to select. The focality will be increased with this high definition electrode montages. The spatial, especially rather than temporal, spatial resolution we can find out more. We can use this HDTDCS more for the manipulation aspect. These electrodes make them to the increase electrical field. When we increase the electrical field with a little electricity, it means side effects also less. The unintended brain areas got into selected to stimulation also become less. So that is the advantage we see the in HDTDCS. The total here, how we calculate in the routine clinical practice also simple. The total amount of electrical stimulation in units is equal to current intensity which we are applying for the 1.5 2 milliampere like that, divided by electrode size. So here electrode size is the in the opposite version. So if you have a lesser electrode size, we will be focus more units with the same electricity, with the same quantity of electricity we can able to apply the patient. So it's a 2 mm of the 2 centimeter of the electrodes which we see in HDTDCS, whereas the conventional tDCS we are seeing the 5 into 7 of the millimeter of the electrodes we are metal electrodes. So the spatial resolution will be become less. It's a target the more broader areas. Then alternate, what are the various form of the tDCS we have to apply here? The traditional we are giving the direct constant current we are applying on the cortex. This is the first one, which we are using the routine clinical practices. Second thing is these next two things are the transcranial alternative current stimulations and transcranial random noise stimulations, where these two purposes we are using commonly in the research. And second thing is the pain modulations I can use it. Though if you are synchronize the brain oscillations along with the train alternative currents also, the person will be feel the more gating pathway will be strengthened that more. So pain modulation will be very easy with this. So various distant effects will lead into the chemical modulation, electrical modulation, and oscillatory modulation. With these three modalities, we have changed the regional level of the activation under activation, and as well as small network level of the activation. For example, I say it's a just any specific response inhibition aspects. Response inhibition, I need to some focus only dorsolateral prefrontal cortex, small network required. Go no go test or NBAC test, which will be make them more sort of the precise locations. Whereas a certain mood level, where the distant large network activities will be there, the craving pathway, various different cravings also there. Need not to only impulsive craving, need not to only reward driven craving. So where if you target the more and more stress related cravings, yes, they are the having of large related network changes are required. So precise clinical outcome we have to divide first. Which type of the disease you want it as a clinical outcome. Based on that, we can select the neurocircuitry networks, which are the accessible over our brain cortex area. Based on that, we can design the protocols. Another more complexity, I can say, it's why some patients are getting the good response, why not some patients are getting the good responses. So what is the reason maybe there? If you are using the HD tDCS or something, advancement of this tDCS stimulation for the precise region you want, the gyre and sulci also will be decide how much the level of electrical entrapment may be happening in that subcortex. For example, gyri, when compared to gyri, sulci pyramidal neuron representation will be opposite direction. The electrical stimulation which we axonal related the stimulation may happen for the cathode, it will be getting to depolarize. Whereas the soma related the anodal stimulation may be become the depolarization. So complete opposite. Which area of the stimulation getting to the more recruited in the axons or soma? Based on that also we have the varied of the inter-individual responses, especially clinically translating responses. So these are the making the complexity in designing the tDCS protocols. This is the in research that they're using in sort of the this much of the individualized, personalized protocol designs. So in that we require the data sets. For example, for the clinical condition, the what type of the magnetic encephalography scans are saying that how much the spatial temporal resolutions are noted for that precise locations. fMRI related, the bold related, the activities we can able to say the which area is the hyperactivity, which area is the underactivity, where we have to target. The quantified EEG scans, which will be broad band spectrums, we have to analyze it. The frontal areas having the hypofrontality. So based on that, we can design the protocols. So these all the data sets will be utilized in the artificial intelligence tools nowadays available with the Comet, Roast. These are the softwares are available in the free of cost also. If you are utilize that, but we need to collaboration with the radiology department also. And the personalized data set, we have to get it all these things. So if you integrate all these things, then we have to easy to design that. They are the nodes of the stimulation where we have to select. Entire these nodes will be represent your brain activity, how much. This is the picture of the whole our individual brain scans. Coming to the research evidence, I am just briefing about that, what the research is until so far. Various studies are there for the, especially in neuropsychiatry aspects. Depression having the first rank, we have the largest evidence with the tDCS evidence. I am not going individual studies. Yes, majority of the studies are using the conventional tDCS are users. Yes, HD tDCS is from 2020 onwards, the research studies are increasing more and more. What happened? All these studies are showing that results are mixed right now because of very varied presentation of the depression. That's one of the reason, and the utility of this tDCS missions and locality selections. All these are making the results are making to the mixed one. Probably effective means probably effective. The conclusion here I am giving for the non-treatment resistant depressive patients. What is effective means at least more than 25 sample size, RCT double-blind studies, which will give the evidence as effective. They say the class 1 level of evidence means a definitive evidence. Lesser than one RCTs are based on that probably first definitive evidence, probable evidence, possible evidence, and inconclusive evidence. Based on that categories, we have given them. So in depression, we are usually targeting prefrontal. We link with the prefrontal asymmetry as a neuropsychiatry theories. Based on that hyperactivity, we presume that right dorsolateral prefrontal cortex. That's why we are applying the cathode here. And hypoactivity in the left DLPFC, we assume that. That's why we are using the here anode applications in DLPFC. This imbalance impairs the cognitive control network of the regulation of the emotion processing in the limbic system. So not the majorly thought level. Once again, I am entirely research on this tDCS. The emotional aspect, cognitive aspects of the symptom will be easy to tackle when compared to tDCS rather than the thought level. So tDCS standard protocols for the MDD patients. So I just now have told that left DLPFC as a using for the anode stimulations more and more. Aims to rebalance the prefrontal activity and restore the proper top-down control over the emotional circuits. The clinical outcomes are showing that improving of depressive symptoms overall and enhancing the cognitive functions, especially in working memory aspects. So it is a combination with your routine practice with the psychotherapies and antidepressant is a having of superior outcomes rather than isolated interventions. Coming to schizophrenia, evidence are showing the papers are showing meta-analysis levels of the evidence are coming as evidence is not enough, robust enough. preliminary results indicate that tDCS is a promising technique as an add-on treatment for the persistent symptoms of schizophrenia. So there is need for that furthermore larger RCT studies are required before concluding as a possible or probable level. So here the circuitries in schizophrenia we target for that. Majorly hypothesis is the altered function connectivity and activity in multiple circuits including frontotemporal areas. Persistent resistant hallucinations will be one of the easy to tackle with this tDCS, where the right side frontotemporal areas and as well as temporoparietal junctions also we can target more and more. Then treating auditory verbal hallucinations, cathode stimulations for the apply for the left TPJ junction to suppress the hyperactivity, which we presume that the source of the hallucinations. Anodal stimulation is directed for the left DLPFC. So what happened here? Significantly reduce the clinically we have seen that witnessing that the symptoms will be persistently reducing severity seen from the 5th session onwards in routine clinical practices. Coming to the OCD related the pathology, we can divide into the premonitory urges like before obsessions, what we get in that. Then second thing is compulsion motor acts. The majorly compulsion motor related acts will be getting to manipulated easily with the tDCS compared to premonitory urges as well as the thought related the obsessions content level. So majorly possible efficacy we can able to say up to so far the evidence what we have from the various RCT levels. The most promising montages will be happen in the cathode over the left OFC or pre-SMA. Yes, majority of the studies the same pre-SMA area means a pre-supplementary motor areas represent of the just antecedent for that M1 area. That was showing that some researchers are using for the anodal stimulation, some researchers are using for the cathodal stimulation. If you wanted to HD tDCS, better to use for the anodal stimulations. So here the OCD related the outcome is we can say it's a emerging one, mixed one. Preliminary results suggest as a decrease the obsessive compulsive symptoms overall as well as anxiety, depression and treatment resistant patients. Then coming to the our favorite areas of the addictions and cravings, where we are the using for the majorly just it's a I can say it's a opposite to your depression. Various site of selection, various number of the studies are having of different of selections are there. But overall, I see say right side of the DLPFC we can target more the anodal stimulation, where the left side we can say is a cathodal stimulation, which is the giving the some research saying that 30% has a low response for the reducing of craving outcomes. Some researchers up to so far 80% also. In our routine clinical practice, it's a complementary to treatment also with the add-on our medications. So meta-analysis level of the studies also there in for the tDCS moderately reduce the craving for especially opioids, methamphetamine, not for alcohol, as per the research saying. Maybe larger studies are required, and as well as the well-sound range of the tDCS missions. Here, tDCS is like a classification of the one treatment modality. Like antipsychotics, we have olanzapine, risperidone, clozapine. We can use for the different characteristics of the patient will be applied for the different medications. Huh? Same thing here, conventional tDCS, the cognitive enhancement training related the tDCS, some sort of HD tDCS. Use these things are depend upon the nature of the patient which we require. Then only patient will be retained. If you use for the any patient, I can use only my own modality of the treatment tDCS. Some patient may not be get the better results also. So overall, in the research of the latest research about the meta-analysis level, therapeutic effects are showing this many indications are there. And in our majorly depression and schizophrenia and ADHD, especially craving phenomena in the various addiction conditions are showing that promising results are there. How to select the protocols, placement, montages, how do we have to show accuracy at least some sort of. First, you have to state your behavioral or clinical target, what you want. Need not to target the entire addiction. It's not possible. We can target it the impulsive nature of the addiction. Yes, maybe top-down control will be less with the especially adolescent age peoples, certain people who are having of personality disorders. Their top-down control will be weakened. So we have to strengthen the cortical controlling capacities. So by that way, we have to target the polarity hypothesis also. And don't be get more so messy about that which area nodes of stimulation, which is the cathode, anode, like that. You select a very good literature, meta-analysis level of the articles on that particular topic, and whichever the things are accessible for us, like a 10-20 system of the EEG placements, which we can able to place the site of the. Otherwise, sometimes different. Even the navigation of the microcentimeters. Don't be worried. Don't be so specific. Maybe clinically varied. So that's why you have to select based on the literature backup with that, which area we have to accessible based on the 10-20 EEG systems. And outcomes of the target also you have to state it more specifically for that. And if possible, yes, your collaborative team approach may be possible. You can use for the run electric field models also. So here the standard stimulation parameters like intensity, yes, what is the commonly effective one is the 1 to 2 milliamperes. Duration, frequency, yes. In clinical practice, 20 sessions, 25 sessions, patient used to just come daily. You can sit for a while, 20 minutes, 30 minutes without any doing activity. I think so. It's a not long run for the patient. Very complex will become the less. So use something very innovative for to engage the patient into the any modality of the tDCS activity. If possible, the cognitive enhancement trainings or emotional training related to the active task. So these tasks complementary with the tDCS modality. Yes, definitely it's a more engaging one and it's a response generating more also. And sometimes you have to more flexible, more than 1 day per stimulation. How much the interval we can able to as a best level, I can say up to so far the literature evidence and backup with it, at least 2 hours. And take a precautions, all these things. So in the literature up to so far 2, but in routine in research institutional practices, they are using up to the 3, 5, 8 also, some patients. What are the contraindications? Yes, relative contraindications are relatively it's a safer interventions only. Only patients who are having of the head injuries recently, having of the any burhole operations are happening in the near any skull defects, history of seizures also there, where the site of your stimulation nearby the focus will be there. Please always be cautious about those things. And metal implants nearby the site like cochlear implant and any electrical implants or something there, we have to please caution about that, especially deep brain stimulation electrodes, where we have the collaborative care multi-specialty hospital setup. So deep brain stimulation, Parkinson's modalities, these things are very commonly happening. So minimal risk is there with the standard parameters. The common side effects which we are seeing, that tingling, erythema, little bit headache, which are the transient mild. Maybe it's a few seconds, even it's a matter of the 15 minutes, 20 minutes. So various conditions of nowadays is approving, including India. So I can say it's a maybe it's a second pillar or third pillar, whatever it be, one of the modality of the treatment. So just now we have talked about the major depressive disorder. The response rate will be seen that within the shorter term, maybe it's within 1 month, 77%. It's a good. Where the anxiety disorders, I can say it's a 40% of reduction. We can see in the latest meta-analytical with the PTSD studies. ADHD conditions, yes, we have seen with the 20 sessions, we can say the 57% of the responses with these montages. And bipolar disorders also having of especially target for the very specific epiendophenotypes like impulsivities and emotional dysregulations. These modalities we can say it's a D size will be the fairly good enough 0.4 also. Whereas the craving, yes, studies are showing that good for the tobacco, good for the cannabis, opiates, but alcohol mixed one, inconclusive one. Whereas the mild cognitive impairments, yes, dementia and Alzheimer's. In early stages of the dementia cognitive decline, I can say it's a little bit pro-cognitive, pro-social behaviors will be more comes with this stimulation, especially anodal stimulation on the over the right DLPFC areas. And OCD, yes, the marginal improvement only I can see it's a schizophrenia, yes, probable up to the more than 30% response also we can target with the especially treatment resistant hallucinations. So who benefits most? People who get the partial improvement with your conventional or treatments like pharmacotherapy and psychological therapies. Those patients add on this tDCS, maybe not harmful. We can use it for the benefit of the patient also. And second thing is the treatment resistant cases, intolerant cases. Some patients may be verbally saying that I don't wanted medications. I want treatment for that. But I don't have time to sit for you for a while to hear the counseling sessions also. I need some intervention. So this type of the special indication patients also we can say. But it's not tested for the intolerant cases like a pregnancy population, lactation population. The evidence are not well enough to say it's a conclusive way. And to accelerate the treatment outcomes, yes, uh, at least you have to wait for the 10 sessions to say it's effective or not. At least as minimum as possible, 5 sessions. As a clinically, if you are well known about the patient for the last long many years, then we can say at least 5 years, 5 sessions will be sufficient to say whether it's an improving trend or not. Yes, patient dropout is a very commonly we see that, especially with the medications, various side effects, various combination pharmacotherapy, various regions also, logistic regions, all these things. So these patients are getting the more beneficial of that. So how to convince them, the patient to retain into the treatment? So starting the treatment, at least you have to wait for the 10 sessions. Then only we can able to conclude whether it's beneficial or not. Don't be get into judge about that 1 to 2 sessions. So these are the assertive statements sometimes. Some patient maybe we can say it's a one session also. We can say it's a some sort of the beneficial effects we can see. So certain alternate as an alternative when medications are contraindicated like a perinatal depression, postpartum depression, IVF, related to treatment related the anxiety conditions, oncology related pains conditions. We are seeing that in the we are using for these patients also, especially the way the 20 to 24 pharmacotherapies already going on. They are worried about that mild depression, mild anxiety symptoms, and mild cognitive declines also coming with their various regions. So these patients are having the beneficial with this trial. Drug interactions also we have to take as a context to take the treatment. So here in our clinic, we are using this the range of the tDCS modalities of the treatments. This is the conventional, just 18,000 rupees of the 18,000, 20,000 of the tDCS mission, which will give the equally effective one, like a 5 to 7 montages, electrode montages. Where the HTDCS is the 1 into 3, 1 into 4 of the electrodes, which we are seeing that is a 10, 20 EG cap. We can fix it. We have the mission also. And little bit advanced one also. This one, the tDCS, conventional tDCS, along with that cognitive training and as well as emotional related the training aspects also stimulations, which will give the complementary to stimulations. Very easy to handle, portable, safe, and what is because least side effect, effective, portable. So all the ideal interventions which we are the fulfill with these things and even cost effective, not a TMS type of 30, 40 lakhs, 50 lakhs, 1 crore, 2 crores. It's not possible. Even for that, some patients also we can able to dispense to the home, but it has its own challenges, ethical challenges also there, not to apply in our Indian settings right now. So safety monitoring and risk mitigations. We can conclude it to 1 and 2. Yes. Medical regulation. Non-licensed device pose a risk to patient. So always we check it whether CDS-CO. Our Indian things are the CDS-CO approved modalities or not. We can check it because they will already having a scrutiny going for the process of the safety all aspects. And protocols also very stringent for that. Manuals, operating manuals also standard of practice also will be more stringent. So we can get into those things. And skin care. So while applying the electrodes, you always feel that make the electrodes placing the sponges will be the wet enough to contact your skin because it is the water which we are wet. The wet thing is effective for the conductivity of the electricity. If you are dry skin, the possibility of the impedance will be more and more. the electricity will be goes the very lesser form, though you are given the 2 milliampere. So wet monitors are required. Adequate pressure, don't be over pressure, don't be under contact, less contact with the skin. And when some sort of, don't be spill over the water from the sponges sometimes, because electricity pass through the water only. So if you are having of nearby the uh, eye something there, so some sort of tingling sensation, electrical sensation the person perceive, so he will be sometimes threatened also. There are certain patients also there. And I have shown some my clinic practice experience, the tighter contact of the skin some leads to burns in the topical burns also happening. So keep all these things. So ensure correct alignment. So these are the important. All session data will be, if possible, in this mission, this especially TES mission, have the all the patient data, demographic data, severity of the clinical things, and as well as the assessment of the tDCS entire the session, how much the current is approximately is going passing through the brain or not. We can get into that. And pre-EEG and post-EEG also the record data, which will show that the electricity rate, the changes are happen or not. We can check it. So this ongoing real time data we can get it also. So safety oversight, immediate alerts for the abnormal impedance and premature termination, we can check it. So the machine will be gives the some signal also. The impedance is too high, so not possible to transmit the power. So then we have to again to rearrange. And protocol adherence also we have to keep in mind. Real time compliance tracking also we can get it that. So overall it increase the clinical transparency. That's what I'm telling. So the session log is what is there. Patient feedback also we can mention that. Each session reports also we can get it. So in clinical practice we have to keep in mind psychoeducation is must before starting of the tDCS. So you have to clear the educate about that what we are going, what were the intended effects also. And what to say the patient to compliance for 20 session means the neuroplasticity will be the our target is neuroplasticity, not the just excitation under excitation. Our intention is the neuroplasticity to create the long sustained durable effects. So 10-20 sessions will be then only we can get it. So make them to the motivate that type of the things. Observe the changes in the halfway mark of 10 sessions also. Just now I have told that. At home right now in India it's an ethical issue. Right now we have to wait it not to comment on that. And relapses, yes, can continue with a smaller dose of medication post successful response with the tDCS also. And sometimes we can say it's a in literature maintenance brain stimulation modalities which will be applied for the TMS also. Even it includes the tDCS. So 3 months modalities will be the usual protocol for the maintenance therapies. So just now I have in cognitive control training for this mission for MDD we are applying here the NBAC test and as well as the to increase the cognitive executive function controls and as well as emotional training also. So person how much he is interpret the emotionals of the various pictures are showing the screen. For substance use disorders also cognitive reappraisal training and tDCS we are applying here. So various already inbuilt programs are also there. The games like type of activities are there. So I am not need not to go for that. What is the versus TMS? How much it's you all know about that. The tDCS is the subthreshold consistent modulation we can achieve. The tDCS offer the comparable antidepressant efficacy to the TMS. So means least cost and comparable efficacy we can achieve. Where the in TMS we are using the magnetic pulses and trained clinical supervision also should be required. Here in tDCS, self-administered safety even at home also reported, including the our nursing paramedical staff also if you train enough, they will also execute the entire the tDCS process. For TMS we need some manpower, technical power, not much of investment are there. So these are all I can say it's a vibes na? For any music, any low melody music, we have to create some good vibes. Then it's become more attractive. So TMS is that type of thing. The setup, the look, the investment, the big size. So here tDCS same modality. You can give the office-based modalities treatment also. But effect as in long run, the effect is matters. So in tDCS, you use a broader network level of modulation also. So I'm not going detail about that each and each everything. So let I skip it this. I am comparing with the ECT also. Yes, both are using for the electricity induced manipulations. One thing is generated for the action potential level of the stimulation that create the seizure activity. Here, just changes the resting membrane potential levels of the stimulation. So it's a safer one. Here we are using pulse type of stimulation. We are using the direct, persistent, constant current we are using here. Slow sustained one. So when compared to 800 milliamperes of the strength we are using for the ECT, here typically maximum we reach for the 3 milliamperes only. So voltage also very lesser voltage we have using for the, and duration is a comparatively it's a short buster one. The patient, the especially important anesthesia is required for the ECT. Here we need not do that. Patient may be sit and awake and aware also we can say. Side effects, yes, definitely it's a mild tingling level, and so these are all things of the regulatory status. Yes, various world countries are showing that it's a increasing trend of the approval is getting more and more. Challenges, yes, in protocol standardization we can get more standard. What is the challenges? So variability of the stimulation parameters, individual anatomy, very important. So it affects the outcomes also. So that's why whenever you have the lack of the efficacy, you can get it. Don't worry, it's not your fault. Maybe the diversity is there, heterogeneity is there, the condition, individual anatomy various also will be possible. So that's why always you are stick on the evidence-based guidelines, which are up to so far the evidence what is directing us. Don't deviate much more on that. Maybe research we can do its hypothesis basis one. Next, second thing is personalized targeting you have to keep in mind. Integration of EEG and fMRI if possible. If you have the multi-specialty, well sophisticated center you have there, yes, better to use for these modalities of the all precision guided electrode placement, montage selections, direction of the E fields, all we have to tailor for the individual. Don't forget it, the change, the world is going to change now. AI driven parameter selection also. So AI related apps also give the machine learning algorithms to select the parameters also. Keep learn from them and utilize if possible what are the data set we have. So advancement in the tDCS is happening recently. That the deeper cortical penetration, increasing focalities is happening HD tDCS. Accelerated sessions also we can plan than the conventional one like less one session per day. It's not possible, so we can improve that also. Personalized tDCS also we can improve it more and more with the tailoring for the various available data set for the individual condition. The safety and clinical experience we have to mention that up to so far the active group and sham group in the literature and as well as clinical practice also more or less same minor transient tingling and burning sensation. Here my clinic experience where the electrode are placing in the raw some little bit and persistent time. So small electrical burns is there. So caution is in the practice is do not treat anode as a just exit, cathode as an inhibitor, as absolute for every brain region and every behavioral outcome of interest. Network activity and its dynamic effects, it's a dosing, it's a timing, which day, which part of the day you are stimulating, maybe morning or evening. If you wanted to streamline one, try to maintain the one modality of the timings also important. So these are all the complicated. It's not the just one. So in-home applications, involvement of clinician must and should. Don't be give the just I am having the mission, I am distributing the mission, you can use it for your while. No, you should still over the session we have the onus of responsibility. So every day, every time, real-time monitoring of the with the tab, we have to monitor how much the current is going on, whether it's a direct constant current level are happening or not. The graphic is shown by the people. If you wanted to give clinic home applications, better to take the institution review board permissions also by the case-based wise and follow the guidelines and publish the safety guidelines. The current status is tDCS CO approved in our country for the tDCS as a therapeutic modality. Experimental research modality is still we are considering this one to maximize the evidence for the depression, somatic pain, then coming by the schizophrenic spectrum condition. Yes, up to so far this is representing tDCS as a cheap, safe alternative to reach the community less access to technological advancement. So overall, this way I can say it's a effective as a third pillar in our treatment modalities in our clinics. Best supported for the depression, anxiety, and OCD, substance use disorder, and ADHD conditions. and medically approved SOPs to translate the research to practical outcomes. Thank you. Thank you all my teachers, elders, colleagues. Any questions?
Thank you, Naveen Kumar sir. You made a complex topic to understand easily. And now the session open for discussion and any questions. And,
That's an excellent presentation. Very elaborately, you shared the evidence base of tDCS for schizophrenia and depression, OCD, addiction. It's totally different area for you. It's like a little bit. I would like to know your personal experience with tDCS. How is it?
Thank you, Prashilesha madam. Yes, madam. In our routine clinical practice, 50% I can use seeing that usually, roughly I can say it's a general psychiatric patients also which are comorbid with the addictions. Addictions treatment. Yes, madam. As it is schizophrenia, depression, and OCD conditions also we are seeing. In that I am applying the mostly with this depression conditions mostly, predominantly up to so far, and especially where the OC compulsions or motor compulsions are there. There I have using some sort of promising good add-on effects are there, and anxiety mixed response are there up to so far. Yes, addiction craving. I am trying for targeting the various sides of the stimulations. Some sort of it's complementary to naltrexone, other various available anti-craving medication. It is added the one of the beneficial effects also. And only one thing is the best thing is so one cheaper modality and easy to administration, and patient pursue with the long-term aspects for the 10 session, 20 session later. Almost all 60 to 80% patients are there saying that some sort of benefits are there. 20, madam. Some, especially OCD, I am going for that. I have educated them 25 also. 25 up to so far.
Thank you, Naveen. Very well done. I have one addition for you, side effect profile. In fact, I have undergone this in hands-on training by the Chinese group in Hyderabad in 2019. At that time, when I applied myself, I developed oscillopsia. That means movement of the objects. Tube lights are moving, something like that. So I think this is one addition for side effects.
So, sir, yes, sir.
Thank you.
In my recent OCD patient, I have given after 25. One patient maybe he is having other antipsychotics also. Partial unilateral doses are there. I am sending to the neurology people also. Let me evaluating about that all the whatever the myasthenia related condition, any autoimmune conditions, even if it's a drug, the tDCS related the let me check it out. The patient is still going on for such.
how safe it is used in first trimester of pregnancy?
Till so far, I didn't had experience with the on the pregnancy population with tDCS application because the electricity. So still the research is also not giving the enough promising evidence on that. So my experience is not there with the pregnancy population, but in theoretically, it's a safer option. Yes, ma'am.
That one, how safe it is? Actually, you touched that part.
Yes, madam. Yes, madam. Madam, when we
You
have
have
the
experience with it.
yes, madam. Up to so far, I'd never given the patient to their home, madam, till my experience. But if your patient is well knowledgeable enough about that, how to operate in the procedures about that, the placement, at least the one finger width of the above of the this EEG electrodes placing of the helmet, then the placement of the maximum scalp contact with the electrodes or sponge electrodes over the dorsal prefrontal cortex. HTTDCs I don't want it to. I suggest not that to give the home because the reference monitors are very peculiar. How much electrical field we have to target, that's very peculiar for that. If you are still the patient is well enough to understand the concept, comprehends to the your guidance of these things, then it's okay, safer.
Regarding when it is being administered, imagine you have taken board permission, you have everything. Who will be monitoring this at home? Patient, imagine patient is doing it.
Yes.
Some technician or
Yes, the technician or clinician also, clinician remote monitoring system is there, madam, with this mission.
from place.
From clinic place to your home.
Okay.
So that our doctor desktop. In the demonstration, we can demonstrate all this question will be there.
In 2014, I started RD. My friends asked me why. I said I'll buy it. The RTMS after 10 years. And by the time 2014-16, we were seeing cognitive spas opening outside IT hubs in Chennai, Hyderabad. By 2017, YouTube was flooded with homemade tDCS machines. People were making with cardboards and connecting with two batteries. By 2021, all of us lost hope on neuromodulation. And then the hope started regaining because of excellent work being done by people like you. Nimhans, they were developing specific protocols telling it doesn't work for everybody, but it will work for few, and let us develop criteria. But around this time, I specifically want to congratulate Marbles and I think brilliant minds from IIT and all. They're joining us. Many have actually bypassed doctors and they've gone on to develop their own vagal stimulation, tDCS, and selling directly to patients. But they're developing approved protocols. And right now, my position is I'm not sure where this journey will go, but we should be a part of this journey, a journey which is very important that will take psychiatry to the next level, that will be very beneficial to our patient population.
True.
Please stay with us and we hope we are with you on this journey also. Thank you, sir, for becoming a pioneer and inspiration to all our younger folks.
Thank you.
Comparing with ECTs, how effective it is?
So compared to ECT, still we have the gold standard. It's a having of lot much of the evidence, backup evidence. So it's a action potential level of the stimulation, ECT, electrical stimulation. So whatever the desynchronization is there between the both parts of the lobe, both lobes of the brain, it will be going to synchronize with various mechanisms which are explained, but no exact one mechanism. But this is the low dose constant current stimulation, and it has a durable effect. We believe that with a safer manner. So maybe it's also promising one, sir, but not in acute conditions. For example, I said say addiction, madam, post withdrawal time. For example, 2 weeks after the abstinence from the alcohol, which are my experience about that. The patient that time, the craving mechanisms are still because of the alcohol induced changes are there. That they are having of hyperactivity, especially frontal cortex areas. So that time, if you have the stimulation on that, especially right side of the DLPFC area, if you stimulate the anode manner, then they have the craving for the reduce. The same thing not happen in the intoxication time. The same thing not happening after 3 months of the time. So the time bound of the experience will be there.
Sir, in ADHD, does it increase the attention span of the patient?
Yes, because frontal cortex are because prefrontal cortex are we are stimulating well enough, especially left side of the DLPFC area we are targeting. There is a executive functions are improving, working memory is improving. The scales NBAC test also showing that objective data also you get it in the especially marble software. These things they are giving that first session to last session. How many NBAC tests they are having the errors are happening. Though they are the cleaning for that learned mechanisms already because of over exposing of the same stools, same tests, they are having of positive effects.
Sir, we have development in ECT like we used to use constant current when we were postgraduates, and later came these brief pulse ECTs. In the same way, do you envisage that the brief pulse tDCS will also come out?
Yes, sir. Still,
because this is a constant current, and there will be some side effects.
Sir.
Constant current.
Alternative current is one of that way, sir. Actually, they are having of pre-pulse stimulation manner because already we are giving the low amperage stimulation. So if you give the pulse manner, the effect will be the very least. The sustained effects, the durable effects, neuroplasticity changes will be lesser with the
Brief pulse.
transcranial alternative neurostimulations. So brief pulse is a lesser modality here, especially
This is
tDCS.
constant current.
Constant currents,
Okay.
constant direct currents, because we are giving low amperage.
Do you have the acceptance from the NLCA to give it to children?
Children's. So children's up to so far it's a not having of evidence we have, back up the evidence we have. But research we can able to the RCT, we can do the institution review board permissions. With that we can implement it for the ADHD condition, autism conditions, when we have to stimulate in that especially SMA areas, anti of the this anti-stimulate cortex areas also we can select it. Yes, sir. These are the low amperage current we are giving, that is a safer for that average or the elderly adult people also. So low current and as well as side effect profile also very less. If you are targeting for the cognitive enhancement stimulation manner, I think so it's a more safer one. Patient with pacemakers. Yes, sir. Just to have told, sir. The at least say 15 to 20 centimeter of the distance if you are maintained with the pacemakers, no problem at all. The electric field doesn't impair that. Let you demonstrate it briefly about it.
There is not a lot of time. Your next session has to start. If you want
Can
to,
remote 5 minutes.
sure, sure.
Two modalities of training. This is what the conventional training is. They see cognitive emotional training one first. Another thing I have the HD tDCS, which is the costly one compared to. So this is the same electrodes are the very not appreciate that much. So we are targeting the prefrontal cortex. Here we can select our own based on the knowledge, which area we can, for example, inferior frontal area also we can select. Especially something somatic pain, functional symptoms, the neurological insult, epilepsy conditions. They we have to choose. It first one. Complete.
Um, so essentially, there were a lot of questions practically that a lot of doctors had asked. So this demonstration would answer a lot of questions. I'll just give a quick brief about how the device works. Essentially, this device has been made to be used very easily. So this is the device that connects to. Thank you. So essentially, one of the practical challenges of using a neuromodulation device in your clinic is that somebody has to be trained to identify what are the stimulation locations. Like Sir has mentioned a lot of locations. So this particular device has been created to sit on your DLPFC, the F3 and F4 locations, regardless of whoever is using it. So essentially, if you wear it such that it is one finger width above the eyebrows, it sits directly above the earlobes, not like this, but directly above the earlobes, then this is your DLPFC location, F3 and F4. So you don't specifically have to train someone to understand with the 1020 EG system to say this is F3 and this is F4. And let's say even if you want to send someone home like a technician, you don't have to make sure that they are trained. Essentially, they just have to make sure that it is one finger width above the eyebrows and it is sitting securely above the earlobes and it will sit on your DLPFC. So this removes a lot of liability and it makes it very safe for whoever is administering it. So you can have a lot more trust on the technician who's administering it that they are not messing it up. And even if you're sending it home through a technician, you are safe in the fact that it is sitting on the DLPFC only. So this is the first thing when it comes to neuromodulation, the location of the device. Second is that setting the protocol, the timing, the intensity, the duration. So in this particular device, you can control everything using a dashboard. Like here in this dashboard, Let's say there is a patient, Rohit Sharma. So in this patient, I can add a session. I can add a single session. When I add a session, I can set the current. 2 milliamperes is recommended. It is the standard national international guidelines. And tDCS duration, you can set anywhere between 10 minutes to 30 minutes. You can also do an EEG. So there's a 4-channel EEG on the bottom band. You can do a pre-EEG and a post-EEG, and once you know how to read the EEG, you can compare how the EEG is changing once you start the session and after 20 sessions. Once you end the complete treatment, what is the response of the patient's EEG? You can compare. Once I can select the date, let's say I want it on Thursday, 30th October, I can add the session, and this session gets scheduled on 30th October. Now, gray means that person has missed the session, they did not come for the session. Green means that the session is completed. There are different colors for partially completed, in progress, etc. So you can also get session insights. So let's say there is a patient who, Divya Padya, who completed a session on 7th of September. You can go to session insights and you can see the session insights. You can see the tasks that they performed. You can see view the EEG graph. Here the advantage with this.
Enter the task selection, the discussion that you finish. So task, each task the person, for example, which, for example, go no-go test we have to require for the increasing of the working memory. So either something emotional component is having of more and more, then you have to give the visualization methods of the stimulations. So here we have the 4 options that they're given the inbuilt. So we can select it 1 and 2 or something depending upon the patient.
Could you show what the games that you have?
Yes, yes.
Will the games be the same, or how do you adjust for practice?
Yes.
So essentially, this is not just stimulation, it is also stimulation. Yeah, this is not just stimulation, it is also stimulation plus cognitive emotional training. The cognitive emotional training is delivered through a tablet interface. And here, as Sir was mentioning, there are around 6 games, and these games are continuously updated to the software. Essentially, these are games like Go No Go, Emotional End Back, uh, Corsi Block, Tower of Hanoi. All of these tests that are originally in neurology, psychiatry, that are used to assess different cognitive and emotional abilities, we've gamified all of that and we've put them in this application. So while the person is being stimulated, some cognitive and emotional training networks are engaged when they're playing these games. And research has shown in one of Sir's slides that when you combine stimulation with cognitive emotional training, the overall efficacy improves because the person is in a more focused state and you are enhancing those networks. So these are some of the games. You can come outside and we can show you how each of these games are.
I have seen one benefit in the research, whether I am giving current really reaching to the brain or not. That I will confirm. This modality of the stimulation is sufficient. Otherwise, the patient impedance and conductness, something, the graph is not like that.
So also something say based on that.
No, something again we have to rearrange something where place is this place or something impedance is more, the spans are not big enough.
So here something interesting to note is that when you give a stimulation like 2 milliamperes, 1.5 milliamperes, it ramps up over a period of 30 seconds. It doesn't directly jump to the amount. It ramps up and it ramps down for a greater comfort to the patient because suddenly if you start giving 2 milliamperes, it feels as a shock to the skin. That's why you have to make the skin comfortable and ramp it up to that duration. Some skins are more sensitive, some skins are not that sensitive. Some people feel it a lot, some people don't feel it a lot. So when people are feeling the tingling and itching and burning a lot, then we start from 1 milliamperes. Then we build that tolerance up to 1.5 in the next session. And from the 3rd or 4th session, you can start giving 2 milliamperes. Just as we build the tolerance up to like a medication or something, similarly we can build the tolerance up to electrical stimulation also. Because of the paucity of time, we are not going through an entire session end to end. But if someone is interested, we can meet outside and we can do an end-to-end demonstration. Essentially, this entire software is given to the doctor as a doctor dashboard, and you can set the treatment protocol for the patient here. Once that is set, all the patient or the technician has to do, they have to wear this, they have to connect the device to the mobile application and start the session. So the intensity of current, the duration of current, none of it is in the patient's hand or the technician's hand. The doctor is the one who monitors how much intensity of stimulation, how much
The
duration.
operating markets, maybe the company people
Yeah.
Second thing is HVTDC. This is one of the risk. So this is the cap for the EEG based one. So there the annular stimulation we have to keep the small surface, the C3 areas. Then reference montage we have to keep the as per the C, the four directions of it, to restrict the electrical field on particular stimulation. So by that way, the intensity of the excitability will be very focused, very to the our clinical point of level, and we have to see that this is a very not technically so sound enough to listen very manual operating mode. And then we have to connect with our laptop. Then we have to get the same type of the electrical stimulation is sufficiently is reaching or not. We can check it. And almost all most of the features will be also similarly same for this HTDCS. Only to increase the focality, to increase the electrical field in that stimulation with a lesser current. The person if lesser current not diffuse to stimulating unintended areas, side effects also less.
That brings back to the question, like for example, in RDMS we spend so much time estimating entry, but here we are settling for very good estimation, same band for all its cases. So even though it is not focal, that is understood.
Like olanzapine, like clozapine, how different.
Yeah.
So that's why I'm not restricted to only one mission. I have the ornamental of the image. tDCS is one modality of the treatment, but we should not be bound with the. Maybe in some patients may be beneficial with this. So we have sometimes the very cheaper 18,000 of the mission cost, just 18,000. We can give the same electrode anode stimulation, cathode stimulation based upon the patient categories.
Yeah, if no further questions, I end up the session and thank you, Naveen Kumar sir, for giving the wonderful insight to us. Thank you. I would like to invite Srisha Madam, presentation to the our presenter.
Request Gangaram sir to give a token. We will move to the last session of the day. It's about research trends in ADHD. Uh, and this will be the followed by the validatory in the hall A. This session will end by 1 o'clock.
See you, sir.